So a very good morning to Dr. Raja and also my fellow classmates. So today the topic that we'll be presenting on is a child with developmental problems. So here is actually a table of contents that we'll be going through today, and without any further ado, let's start off by looking at the first condition. And I would like to first start off with just a case scenario. So here we have a 2-year-old boy who presented to your primary care clinic with fewer words than his peers, and his parents also mentioned that non-family members have difficulty in understanding him. And on closer questioning, we found out that he actually had less than 10 words of speech. He is actually born at term at 39 weeks by normal delivery, and he also did not require any special care baby unit after that. Other than that, he also passed his newborn training screening, and on review of his pin book, you notice that he had consistent growth along the central lines, and he did not have any problems with his developmental milestone. So I would just like to ask the audience here, maybe based on this case, what is your provisional diagnosis? Maybe just based on the case itself, like what does it point you towards?
Slow development.
Slow speech development.
Yeah, correct. It's actually a type of speech delay and language delay. So maybe I'll just like ask Jian, since you answer about speech delay, then what is your further step in your, like what else would you like to do in your next step?
Maybe I will like assess the speech development with like certain tools available.
Yeah, correct. Maybe I believe you are trying to say you want to examine the child first. Yeah, so that's correct. And on his examination, you notice that in the consultation room, he is playing appropriately. He can make good eye contact. He can also follow your instructions. When you actually examine his face, there is no dysmorphism. And you also do the hearing test, and you noted that on otoscope examination, there's actually bilateral non-tympanic membrane. But maybe I'll just like you all to remember that on the examination, you only found that there is abnormal findings on otoscope examination, and we'll hold this case for a while. And let me just explain more about speech and language delay. So when we actually talk about language itself, it is a broad term that also includes speech. And if we look at language, it can be divided into two different aspects. One is your receptive language, that is referring to the ability to understand what is someone talking. Another one is your speech, also known as your expressive language. So this is actually about how is the ability of a person in conveying their information, their feelings and thoughts and also ideas. And generally, in children, they tend to have a better receptive language as compared to their expressive language. And when we actually talk about speech and language delay, we need to know that the pattern and sequence are still normal. It's just that it occurs later in age, and that is why it's called as delayed for their age. So then coming to the epidemiology, the prevalence of language delay among those who are 2 to 7 years old is noted to be 2.3 to 90%, which is a very common developmental problem among children worldwide. And if you look at those who are in between 2 years old, nearly 30% of them are thought to have delayed onset of speech. So when this becomes pathological, it is also known as this speech and language disorder, which affects up to 8% of the children. And by age 5, 90% of them are already have identified to have speech and language disorder, among which 6.4% of them have speech impairment, 4.6% have both speech and language impairment, and 8%, which is the majority of them, have language impairment. And when we speak about speech and language impairment, it is generally having a male predisposition, and boys, they are said to be nearly 2 times more likely to be affected by this speech and language impairment.
So, from your epidemiology, a lot of children actually catch up. So if you look at the 20% of 2-year-olds who are thought to have delayed onset of speech, but only 90, I presume 90% of that 20% are identified to have speech and language disorder. Is that what you're saying?
Yeah, actually, because usually at 2 years old, that might be just a normal physiological kind of the delay onset of speech. But when it becomes pathological, it's usually identified after the age of 2 years old. So when at 20%, there might be more children that have this delay onset of speech, but later on in life they actually pick up and they are able to. It's not pathological yet, but among these 20%, about 90% of them, when they reach 5 years old, they still do not have a proper development of the speech, and therefore it comes under these speech and language disorders.
Yeah, so my point is that a lot of children actually do catch up.
They catch up.
Yeah. That those numbers look quite high. The numbers is about 60% who catch up by the age of 5. But okay, you were saying about 80% catch up by the age of 5.
Okay, then maybe I'll just move on to the next part. So we will just actually look at what are the etiological factors or even associated factors of a speech and language delay. So the first thing when we look at a child with speech and language delay, the first thing that we have to assess is whether or not they have this hearing impairment. Because without hearing, they will not be able to develop speech and also language. And another thing is that we might want to rule out global developmental delay because in children, there are also a large number of them might also show problems in their other intellectual functioning and not just their speech and language. And usually these people, they are termed as diagnosed as global developmental delay. And this diagnosis is actually not 100% because sometimes those children or even individuals who are not able to undergo the systematic test assessment, then they will be also diagnosed as this global developmental delay. And the reason is because if a child is too young, they will not be able to understand you. So the test that is being used will not be applicable to them at such a young age. Okay. And then another thing that is commonly associated with is if there is environmental deprivation or the lack of opportunity for social interaction. And the most characteristic example is parents with language difficulty. For example, if they are mute, then this will actually impair the development of speech in the children because they were not exposed and they were not given the opportunity to also speak and also develop their language. Then another thing that we should also note is that is there any positive family history of speech and language impairment or even language disorders among the family members? Because generally, sometimes we do see there is a genetic predisposition to this condition. And a very interesting thing is that studies have also actually noted that bilingualism or children who are actually growing up from a family that speaks multiple language, they tend to have a delay in starting thought, and sometimes when they talk, they do mix elements or words from different languages.
But they do kind of catch up. I mean, it's
Yes.
just initially, very initially, when they start talking, they might be nervous, but you know, it doesn't mean that one should stop talking.
Right. And then another thing, the study also mentioned that sometimes they also mentioned about how twins birth or the laziness or even tongue tie is also a cause of this speech and language delay. But however, there is still not enough adequate explanation to actually mention that these are the cause of a significant language delay among children.
So tongue tie is a myth. Okay, so I do not know where it comes from, and all these kids, you know, I think I'm sorry, I think sometimes it's the ENT surgeons who feel they can gain a lot from this, but yeah, that's a definite myth.
Okay, and then moving on, we just look at the clinical features. So when we actually speak about speech and language problems, it can be further classified into primary and secondary. Secondary means that there is underlying condition, medical condition that predispose them to having a speech and language delay. But over here, I would like to just focus on the primary part. So primary is actually idiopathic, there's no cause to it, and under the American Academy of Family Physician, they actually divide this primary speech and language problem into 3 different diagnoses. One is your just developmental speech and language delay. Then we also have the expressive language disorder and receptive language disorder. So when we talk about the developmental speech and language delay, generally the child will present to you with speech delay, and when you try to assess them, you find that these children, they do not have any other problems in their developmental milestone. And when you do some cognitive assessment, you note that the child have normal comprehension, normal intelligence, they have normal hearing, they can emotionally relate to others, and they also have the normal appropriate articulation skills. But however, when they are actually younger, it might be difficult to differentiate expressive language disorder with this normal developmental speech and language delay, because generally expressive means you're trying to speak speech, and if they actually do develop this problem with expressive language disorder, you might not be able to catch it when they were still young. And then another one is your receptive language disorder. So a characteristic finding of children with this receptive language disorder is that when the parents try to tell them about an object and ask them to point towards that object, they will not be able to do so because receptive means they are understanding. Basically, they do not understand you, so how do they respond to your cues? Yeah, and also with those with this receptive language disorder, they will develop more problem with their speech as well because they don't understand you, so they will not be able to form proper sentence. You will note that their sentences are actually sparse, their grammar are full of mistakes, and their articulation part is also quite indistinct because they actually cannot catch how you are trying to pronounce the words. So on the right side is actually the diagnostic criteria that I've obtained from DSM-5. However, I would just like to put emphasis that when it comes to diagnosis of a speech and language disorder, you first need to rule out a lot of things. For example, your hearing impairment, whether or not it is secondary to any underlying condition, for example, your autism, your cerebral palsy, or if let's say there's any neurological abnormalities in the brain that can cause this language and also speech disorder. And this is actually a picture. I won't go through all the diagnostic criteria. You can just read through.
And the other one is global developmental delay. Basically, many children with global developmental delay will go on to have intellectual disability. So global developmental delay is 2 or more skills, so a motor skill, speech skill, which are below your achievement for your age. Yeah, so
So then another part of these clinical features, I also included the secondary causes of speech and language problem. But I guess this one I'll just keep it for you all to read by itself, because my primary focus here is not the pathological one, but just the primary cause. So coming to the most important part is how do you assess a child that comes in with this speech and language delay. So it can be divided into 3 different evaluations. The first thing you want to do is a psychological evaluation, which includes your cognitive assessment and also evaluation of social behavior. So let's look at this cognitive assessment. It's very important for you to perform this because you want to differentiate if it's a primary cause, which is known as your specific language impairment, or is it due to your intellectual disability or mental retardation. And how to differentiate is that based on the results, you will note that people with this, children with this intellectual disability, both their verbal and non-verbal scores are low, that is below the 2nd percentile. But for a specific language impairment, their non-verbal IQ is still within the normal range. It's just that they are not able to speak out verbally, and that's why it caused their verbal IQ to be low. Yeah, and then another thing you want to evaluate based on your psychological evaluation is the evaluation of your social behavior, and this is very important for you to pick up autism or pervasive developmental disorder. And therefore over here you can actually see that for those who have just normal speech and language impairment, they will still have an interest in social interaction. But autism, the characteristic feature of it is that they do not show any interest in social interaction. And yeah, that's why you want to rule out autism by doing this evaluation of social behavior. Then another aspect of your assessment should include speech and language evaluation, so that you assess their language, their speech, and also their physical mechanism that is associated with their speech production. For example, if they have any problems with their tongue, any maybe problems in their pharynx that they are not able to properly perform or actually make sounds of the words and all. Then the last one is definitely your medical evaluation that includes your history taking and also physical examination. So some of the parts that you want to pay focus on your history is definitely your family history. As I mentioned, it can have genetic predisposition, and you also want to find out if their parents are not only having this speech and language disorder or delay, you want to know if they are deaf or mute, and another thing you want to know if it's a blood-related marriage, because this can also increase the chance of inheritance by the child. Then another one is during antenatal history, you should also ask about if there is any maternal illness or infection, your tortious infection. Then you want to ask if they are taking any drugs, any alcohol or medications that can be toxic to the neonates or the embryo. And then you also want to find out if there is any smoking history. As for birth history, you would like to find out about the prematurity or perinatal asphyxia. Asphyxia is actually a condition where there is lack of blood flow and also oxygen, and this can actually impair the development of the child further on. Then for postnatal, you also like to find out if there is severe neonatal jaundice, hypoglycemia, seizures, and then for past medical history, find out about any serious childhood infection, and especially your chronic ear infection, any past hospital admission or trauma. Then for social history, very important to know that how is the stimulation from the family that is going on, and whether or not the parents are communicating and also providing them with appropriate stimulation. Yeah. Then for developmental history, you want to know you want to get more information about their quality, their quantity of speech, and also whether they have any other problems with their developmental milestone that includes your gross motor, your fine motor, and also your social behavior. So coming to physical examination, definitely you want to take their head circumference, their height and weight to see if their growth is abnormal or not. Then you would like to look at if there is any dysmorphism or any neurocutaneous markers. Then definitely you would like to do a neurological examination to look for any abnormalities or any signs that can be found in their neurological system. Then again, you must definitely examine their ears. And distraction test is actually an examination that we do to determine hearing impairment. And this distraction test is generally an alternative to audiometry in children, because in audiometry you require the person to understand you that once they hear the sound then they have to press, but for children they will not be able to do so, and therefore they actually come up with this distraction test, which is basically just to distract the child and see if the child responds to your cue. Yeah. And then other thing we can do is also assessment of the expressive and receptive language, and then you want to do a full developmental assessment and also observe how the child is interacting, playing, and also what is their social behavior like. Okay, then coming to the most important part, management. So definitely you would like to first investigate by doing some visual and hearing tests to ensure that they do not have any sensory impairment. And then if you pick up any dysmorphism on physical examination, then you would like to proceed with genetic testing, which includes molecular karyotyping, or you want to request for specific tests to identify syndromes like Fragile X. And Fragile X is actually this little boy here. They will actually present with broad forehead, elongated face, large prominent ears, strabismus, and also high arch palate. But other than that, you can also pick up and request for specific tests for Prader-Willi and also Angelman syndrome.
Okay, just so the distraction test you were talking about, if you do it in a clinic setting, it's very inaccurate. You should send for a hearing assessment if you suspect it. A lot of the suspect hearing impairment. A lot of the children now, when they have newborn screening for their hearing. Yeah. So if it's an isolated expressive speech delay, so if it's just a speech or late talker, but their understanding seems normal and their newborn hearing screening is normal, then you don't need to send for a hearing assessment. Yeah, but the distraction test is very inaccurate. How do you do it in a clinic with lots of noise going around?
Okay, and then coming back to this investigation part, so then you can also request for Prader-Willi syndrome. Usually this child, they will present with obesity, they have short stature, and then they have this low nose bridge. And then for Angelman syndrome, it's basically this child here. You have hyperreflexia inflexicate, and their mouth is actually, they will show like characteristic upper lip is actually thin and the lower lip is broad. Then if let's say you do find any abnormalities in their genetic testing, then we want to refer them to a clinical geneticist for further evaluation of what is the genetic mutation. Then definitely you also like to order a baseline investigation, which includes your full blood count, your serum urine electrolyte, your thyroid function test, or even your urinalysis. Then if let's say there is presence of any neurological abnormalities, you would like to also do an MRI brain to look for the structural abnormalities. And if there is history of seizure, then you'd like to proceed with an EEG.
Okay, well, more often than not, we're talking about just primary, speech and language or primary language disorders. So you don't necessarily have to do all those investigations, and all the children. Otherwise, you'll be overloading the system. Okay. So that is if only if there are dysmorphic features or whatever, and then at your level, you're going to refer to the specialists.
Then coming to after the investigation part, so as what doctor has mentioned, the first thing from our part here is to refer them to pediatric neurologists or even developmental pediatrician or even audiologists and speech language pathologists to further evaluate them. And I also included some pointers
The pediatric neurologist will be really annoyed if you refer them just a normal, late talker. Actually, most are managed. As I said, primary language is so common. Primary, late talker or speech and language late is so common. Okay, most are managed in the community by the MOs. They will just review them. Yeah, or just the pediatricians. But even the pediatricians they're like, if this looks like a normal, speech and language, just the delay, then they're not even keen to follow up. Okay, so because we know a lot of them will catch up. So the key is identifying that that this is just the speech and language delay and not something else. Now, if you think there is something else, like an autism is part of a secondary type of condition, then only you go on and refer.
Yeah. So as what Doctor mentioned, if there is features in the history that is warning signs, then only you would like to refer them. And yeah, actually the picture here on the right, both are actually indicative of the warning signs, but I guess you all can actually read about it later on. And then if let's say they really do not catch up with their age, then you might want to refer them to have this speech language therapy. But from our part, the most important thing that we want to do is to counsel the patient. So first thing, you actually might want to monitor and so review them frequently. And another thing is that sometimes they might ask you about like how is the speech language therapy and all. So basically, according to the data that's available, most children they do show positive response to the interventions such as the speech language therapy, or even if let's say they have a problem with their hearing or neurological abnormalities. So once they are treated, usually they will still be able to show some improvement in their speech and also language skills. And then if let's say they do have other developmental or behavioral problems, then we might need to be honest with them and don't hide the fact that they will definitely be okay. But in actual fact, sometimes they may be improving as they grow up, but sometimes they might not even have any improvement and this problem may still persist. Then another thing, we want to encourage the parents to use a lot of sign language or any other alternatives like pictures to actually stimulate the learning of language. Then you can also teach them how to do some language stimulating activities. For example, tell them stories, sing some child songs to them, and then you can also name the thing, which is just a picture that you show them and you ask them to name the object, and so on and so forth. Then another thing, we can also do recreational reading in those children who are much older already. Then this is actually just to expand the child understanding of the language. Yeah, so I hope.
You did mention there's some evidence that screen time more than 4 hours a day has been associated with speech and language delays. So, not too much screen time. We need to counsel them because screen time is one way. A lot of parents just feel that they learn a lot from whatever they're watching, but actually many kids, they're just watching the pictures. They don't move very fast, they're just watching. Yeah. So, and they're not, language is like everything else. You need to practice it. If you just, one way meaning you're just watching what's on TV. And if it's prolonged, you're having a lot of screen time. That can cause problem with your speech and language and attention as well.
Okay, so yeah, coming back to our case scenario. So I hope from my presentation, it is understood why you want to pay more attention to the ear examination. And yeah, so maybe any one of you would like to mention what you would like to do next after you note that there is an abnormal finding on the otoscopic examination.
Do a hearing test.
Yeah, basically you want to refer to the audiologist to perform a hearing test. So in this case, yes, the child was referred to an audiology, and then they also did antennometry. Then they found out that this child is having mild to moderate hearing loss with a hearing threshold of more than 40 decibels, and the tympanogram is also flat. So this is actually indicative of otitis media with diffusion. So then this child was then later referred to the ENT, and then they actually follow up for 3 months, and after 3 months they showed the otitis media did not resolve. So then they actually did a grommet insertion, which is a tympanostomy tube to release the pressure for the middle ear.
And then on follow-up at 2 years and 6 months, there is indeed improvement, whereby his vocabulary has really expanded to more than 100 words, and the audio rhyme becomes normal, whereby his hearing threshold is already in the normal range that is less than 30 decibels. So I hope this explains about the speech and language delay, and it's also association with the hearing impairment.
So otitis media with diffusion, you get conductive hearing also. It's not sensory.
Okay.
So pass it on to next speaker.
I think so.
Okay, so now we're talking about dyslexia.
No, it's okay.
So definition of dyslexia is basically a learning difficulty that usually causes problem with reading, writing, and spelling. And usually in dyslexia, the intelligence isn't affected. So for epidemiology, in UK, estimated about 1 in every 10 people has some degree of dyslexia. But in Malaysia, however, I did not find any statistics available, but it's estimated to about 4 to 8% of the school-going children have dyslexia, and more boys are affected as compared to girls. So for the symptoms, it definitely varies from person to person. So they actually divided it into the age group. So firstly is preschool children. They will have delayed speech developmental as compared to other children who are in the same group. They will be not able to pronounce long words, or they will jumble up phrases like helicopter instead of helicopter, and they have problem expressing themselves with it's difficult for them to use the right word, or sentences are incorrectly used. They have difficulty appreciating rhyming words like cat sat on a mat. Yeah, it's difficult for them, and also they have difficulty or little interest in learning letters of the alphabet. So in primary school children, here the symptoms become more prominent, and they have problems with names and sounds of letters, spellings inconsistent or unpredictable. They have confused letters that are similar, like letter B and D. They confuse the order of letters. Their reading are much more slow, and they make more errors, especially when they read it aloud. They have difficulty writing answers down. They have difficulty carrying out sequence of direction. They struggle to learn sequences like Monday, Tuesday, like the days in the week. They have slow writing speed, poor handwriting. It's difficult for them to copy down anything that the teacher is teaching. They have poor phonological awareness and word text skill. Poor phonological awareness is basically they cannot understand the same word like hot and hat.
Phonological awareness is knowing what the sound of the letters are, or the words are. That's how we actually start to read. So actor, see if it's correct. And it's tied up with speech and language delays. Some parts of the brain, the superior temporal lobe, the superior part, which is involved with speech and language, is also involved with reading and phonological awareness. So that's why you have a background of speech and language today. So especially those with speech and language disorder. So about 40% of children with speech and language disorder, so that's 5 years and above language disorder. Yeah. Language disorder from 5 years. Well, if you're diagnosed with language disorder from 5 years onwards, then you are at risk of having problems with dyslexia. We don't use dyslexia is a subset of specific learning disorder. So specific learning disorder encompasses dyslexia, dyscalculia, dysgraphia. Yeah, so it's basically you have a normal IQ, but you have problems with your skills learning.
Then for teenagers and adults, you can see that they have problems expressing their knowledge in writing, difficulty planning essays, revising for exam will be difficult for them. They try to avoid reading and writing as much as they can. Poor spelling, and also things to remember like their password for their phone or their telephone number is difficult, and they also find it difficult to meet deadlines. So for assessment in the history, we have to focus on these key things, which are ask them if they have currently any learning problems were noted, any problems faced in school, and take their developmental history, family history of any similar
speech delay or learning disorders, if they have any significant birth and medical history, any schoolwork assessment in their exams, how are they doing, interventions and extra support that they are actually getting currently. Then for physical examination, look at their growth parameters, any microcephaly, any hearing or visual impairment, any syndromic faces, neurocutaneous stigmata, and also do a complete neurological examination to rule out anything. And also important to look at their developmental assessment. Look for coordination, motor sequencing, balance, their fine motor, their receptive and expressive language, their reading and their understanding, their phonological awareness, verbal, short-term and verbal working memory, and also observe their behavior. Then from there, it's important to note that not all depends on their clinical presentation. Some of them actually do not require any investigations to be carried out. But in case they need, then actually a questionnaire will be sent out to actually assess how they are doing and everything in school and what problems they're currently facing. Then they actually observe the child and also get necessary information from like key adults in their life, like teachers and parents. And from there, they actually do certain tests to examine these components, which is their reading and writing, their language development and vocabulary, logical reasoning, memory, and their speed to process visual and auditory information, the skills to organize things, and how they approach their learning. And from there, actually, they will receive a report and possible recommendations of what they should do. If they need any special education or anything. So then, for the management, it actually involves parents as well. So for the parents, they should actually read to their child so that they can improve their vocabulary and listening skills. They should make reading fun, like choose subjects that they are interested in. Share reading, that means both of them read and then discuss things and discuss what might be happening during their reading. Silent reading, which is encourage them to be independent and let them read on their own. And also overlearning. Overlearning is, although it may be like boring, but repetition and will help them understand and become familiar with the text. Then for educational intervention, they should do like regular teachings in small groups or either one-to-one lessons with a specialist teacher. Then they can do phonics interventions, make them understand, let's say hat, like the difference, HAT, and all that. And for multisensory teaching, maybe tell them like A on writing, how does A sound like, and that kind of thing.
So multisensory teaching is if the child receives feedback from several sources while trying to pronounce the letters. So like, sometimes with dyslexia, really basic, just recognizing the alphabet is a problem. So you get them to trace an A on a rough surface or in sand or something like that, and actually say the letter and sound of it before it says what they're tracing. So you're giving feedback through several senses for the child, and so they're saying it, they're tracing it, they're feeling it in their fingers, so they can remember it better.
So this is also a short discussion of the use of technology in people with children with dyslexia, because they are actually more comfortable using technology as compared to like physical exercise books. Because actually maybe it's because computer uses visual environment as compared to writing, and also they can use word processing programs like spell checker and autocorrect facility to help them, and they have the text-to-speech function and also speech recognition software that can help translate what a person is saying into something written, because in most cases their verbal skills are better than their writing skills.
You're right. The COVID lockdowns have shown that actually it isn't one-to-one teaching. So one-to-one meaning learning from a teacher, okay? But they are very, very good programs, which are very helpful. So it's complementary. It complements. But honestly, learning from a good teacher is a lot more effective. I mean, you know, if you just sit the child in front and just expect them to learn from the computer, you know, they actually, a lot of them have attention problems as well. So not that easy, not as easy as you think. Just having a computer, you know, take over a teacher's role. In fact, they found that the learning skills for children in general, I'm not talking about dyslexic children, were worse doing online, just doing online type lessons. I found that from the medical students. I find the clinical skills, I'm sure a lot of people are not listening to me as well. Okay. So,
And lastly is the associated conditions. Can be associated with difficulties with numbers, dyscalculia, poor short-term memory, concentration problems, and short attention. Can be associated with ADHD also. Poor organization and time management, and lastly dyspraxia, which is physical coordination problems.
so again, about 40% of children with specific learning disorder will have problems with ADHD. Dyscalculia is not as common as dyslexia, probably because this mathematics skills uses many parts of your brain. Okay, so that's why very good mathematics skills are in great demand. So it's less likely you're less likely to have problems with all those different parts of your brain. You know what I mean? So you can use other bits of your brain to kind of compensate. Whereas reading is a skill which is, you know, reading and spelling, writing, more concentrated. The areas which you use of your brain to read and write. Write, when I mean write, I mean essay writing. Yeah, it's all tied up with dyslexia, spelling, essay writing.
That's all.
Dyspraxia is motor coordination difficulties. These can be difficulties with your essay writing. We find motor skills, but those as well, so you figure that's what they're coming.
Alright, so next up we have temper tantrum in children. Okay, so first of all we have to know what exactly is a temper tantrum first. And in this case, it's actually referred to as brief episodes of like extreme, unpleasant, and sometimes there might be a bit of aggressive behaviors in response to frustration or anger in children. And usually it's like disproportionate to the situation. For example, what do I mean by disproportionate to the situation? Let's say like maybe the child like maybe cannot have the toy that she wants, but they will get very angry. Maybe like they will like smash things or like throw the things around. It's like the anger of them coming up is it doesn't make sense, or it doesn't match up with what just happened. And also, although the majority of the temper tantrum in toddlers are like typical and also part of the normal toddler behavior, but we also have like what are the abnormal tantrum is like. So we'll just take this slide first. So for a normal tantrum, the age is usually from 12 months up to the age 4, and their behavior during tantrum is usually like crying or like maybe like flailing of arms or legs, and also maybe falling to the floor, or like they push, or like they pull something, or like they bump to something. And usually it wouldn't last for very long, probably like up to like 15 minutes at most. And the frequency wise, it wouldn't be more than 5 times a day. And the child's mood should return to normal in between the tantrums. However, what do we consider as abnormal will be where the temper tantrum lasts past up to 4 years old, and the kid will injure themselves during the tantrum, and each of the episode lasts longer than 15 minutes, and it will be more than 5 times a day. And even let's say like episodes, let's say at 12 p.m. and 2 p.m. But in between these two temper episodes, the kid will also have a very negative mood, and it doesn't seem like he wants to talk or anything. And also, these are what we can take note of in the case of an abnormal temper tantrum. Alright, so we'll just look at the epidemiology of it. And usually, most commonly occur between the age of 2 and 3, but it may start as young as 12 months young, and around is the temper tantrum comes at around 87% of the 18 to 24 months old, 91% for 30 to 36 months old, and 59% for the 42 to 40 months old. So it's quite common to have tantrum at least once a day, because like I'm pretty sure all of us have seen like babies or like young toddlers, they will just get upset quite easily at some certain age of their life. And the case where is 20% for 2 years old, and 80% for 3 years old, and 10% for 4 years old. So we can see that the figures should go down as the baby grows up, because after you grow, you will know like you get to control your temper better in a way, like you don't get upset or frustrated so easily. And oftentimes is you like associated with something, maybe where the kids is tired or like hungry or sick. Like we get to see let's say like parents are bringing this 2-3 years old child to a shopping mall, and after a long time, if the child is walking on she on his own, then maybe they get tired and they want the parents to like carry them, otherwise they will feel like they will just start crying, and then they will just throw tantrum in the shopping mall or something like that. I'm sure it's something that we get to see. So however, there are no documented differences in the prevalence of tantrum by the gender or even by the race or ethnicity. So it's something that it's just the same for the all children. The only difference differ by the ages and the months old. And the child with language deficits, like what we had discussed just now, they may have more frequent and more aggressive tantrum because they do not get to express themselves well through language. So in the sense where they want to express their upset or like on certain their frustration, they tend to just throw tantrum because they have difficulty in expressing themselves. Right.
Sorry, your percentages, 87% of 18 to 24-month-olds have tantrums, but then it says common for toddlers. The figures which are correct are the ones common for toddlers that have tantrums at least once a day, 20% of 2-year-olds, 20 to 50% of 2-year-olds. Yeah. What's those figures up there? 87, 91%, 59%.
Which video? Yeah, I think it's the how prevalent it is in the months old.
But they're completely different from
No.
the second line, third, fourth line.
No, I think the one will be.
Could be. The normal.
Yeah, and that one is for the once a day one, I guess. So it's like looking at the like once.
Or just overall,
Yeah.
children who have tantrums, 87% would have had some sort of tantrum.
Yeah.
So I think, okay.
Alright, so for us to know like whether this tantrum is a developmental issue, psychological issue, or physiological explanation, it's important that we have a thorough history and a physical examination to know like whether this outburst is just a normal tantrum behavior or just a atypical one which you might have to consider to refer. But in most cases, we don't really refer to a specialist like a doctor you mentioned, unless like there are really some red warning sign to take note of. So the provider should actually take a thorough history. So usually we have to ask the parents like, tell me about tantrums, because it's important for us to know like to differentiate like whether is it because the child is just hungry, or like there's really something that's going on, there's some pain that's going on that the child wouldn't know how to describe. So it helps us to eliminate whether is it some physiological condition or whether it is some developmental issue. So besides that, we might also have to look into how is the family dynamics is like, because it can help us to understand, could it be, is it some parental behaviors that is causing the child to have such behavior? Because we understand that a child's behavior is actually very closely related to how the parents behave, in a sense where if let's say the child has a father at home that's constantly throwing tantrums and scolding the mother most of the time, maybe a child will mimic it and like it will just cry and scream and like lash out whenever it gets dissatisfied in certain way. So this is something that we also have to take note of, the family dynamic. And also we also should recommend the caregivers where they can actually keep a record of like the tantrum. So we know that, if we actually look at the record, it's like my child is having 6 to 7 tantrums a day for like every single day. But maybe this is something that is too often and the pattern is like showing us something where we have to take note of. So some of the questions that we can ask are like, when will the tantrum occur? Like what times of the day? Is it suddenly halfway throughout the day, or is it when the baby just woke up from a nap and is hungry or whatsoever? Or like what circumstances will precede the tantrum? Or like what behaviors does the child demonstrate? Because this is another thing to take note of. Some child, they tend to have this breath holding behavior during tantrum, where like they just hold their own breath and like in order to fight back, or like that's their angry way of acting and all. And some child will like maybe hit themselves with the wall, like they will go bang on something. So these are some of the behavior that we need to be extra careful and take note of, because it could actually show us through maybe she is having some developmental problem as well, or how long do the troublesome and undesirable behavior last, because like duration is something, or like what is the caregiver's reaction to the tantrum. And this is another thing that's very important, because if the parents are not reacting well to the tantrum itself, it's likely that the tantrum do not get resolved well in the end as well. So we will talk about how do we handle the tantrum later. There's another one, or like the child's mood between the tantrum and episode. Any changes to the home or school circumstances? Let's say it's already a kindergarten school going children. Maybe like before going to kindergarten, she is fine until like after starting going to school, then the child is getting more and more moody and throwing tantrum all the time. So maybe we have to consider that is there something wrong going on with the school? Maybe it's being bullied, or like it just that didn't like the school environment. So that's something to take note of. So, and is there any change or move in the family structure when family conflict is especially important, or like any scary thing or like upset incident that will happen to the child, or any behavior that's concerning the child's function. So these are the things. Like we can also see if there's any sleeping issue, or any like you can see your child is getting more and more anxious, or any loss of bladder control. Okay, so next one. Yeah, in order for us to help manage this situation, we have this acronym called RIDD. So firstly, you have to remain calm, and we also, by let's say like, if the child is biting on the parent's hand, or like to bite on certain things, you have to be very firm, but at the same time, you have to be calm. Like let's say like, I want to tell my child, oh, no biting. But if my tone will be no biting, it's like it will give the child in a different sense of like your expression of the mood. So you have to remain calm and actually be neutral with your tone in order to tell the child your instruction of what they want. So that will be appropriate to the developmental level of the toddler. Second thing is ignore the tantrum. So there's one of the recommendations they have, but because if you keep on entertaining to the tantrum, the child knows that, okay, so the next time I want to get something, I can just throw a tantrum and my parents will allow me to do so. It's kind of, in a way, you are reinforcing the child's behavior. And the third thing is you may distract the child by, let's say, you just leave the room or you go somewhere and like let the child to have the tantrum and stop on its own. And lastly, you will say yes when meeting the child's physical and safety needs, but don't give in to the demand. So it depends on what situation the child is throwing the tantrum for. Let's say we understand that my child is just hungry right now and it needs to eat something, so maybe I can give in to it. However, if it's like very undesirable request, or let's say, I think oftentimes this is something that we see in a shopping mall where the kids want to buy a certain toy, but then like the parents say no, and then you see the child like crawling on the floor and pulling their parents' leg and started crying. So it's things like this that you have to know as a parent, do you want to say yes and give in to situation like this? And because if you do, you will kind of give a positive reinforcement into their behavior, which will actually further like worsen their tantrum. So as a healthcare provider, you should always provide the parents some reassurance that tantrum is part of the normal and healthy child development, and like we recommend them on how to manage it by doing this RIDD strategy. And most importantly, we should know that which are the situations to be referred. Like let's say we see some behavior that's undesirable, like knocking the head, or like very long lasting tantrum. So these are the times that you need to like refer, because breath holding spell, that's not what we want. And prevention is always the best way to handle frequent and recurrent tantrum. So we should know that how do we remove or mitigate the the triggers that may lead to tantrum. So some of the things that such as the associated factor like fatigueness, hunger, and also illness. So if we can prevent it, it doesn't happen, that is even better. So we don't really need to handle it. Alright, so this will be for the temper tantrum, and we have some questions, simple questions. So which of the following questions can help a provider to understand the events before, during, and after a tantrum?
Donkey.
Yeah, so all of the above here will be a appropriate question that we can ask or help us to elicit more information. And secondly, we have which of the following recommendation can help in managing the tantrum? Yeah, with all the above as well, we provide reassurance, we ignore the tantrum and restrict the child. And lastly, what are the percentage of the 30 to 36 months old are likely to experience tantrum?
Boy.
And we will go back out. It will be 91% for the 30 to 36 months old.
So we don't recommend corporal punishment. Corporal punishment is hitting and all that, because we find that the child is likely to react when they're angry and they have a tantrum. They are likely to react physically as well. So common practice here.
Good morning, doctors. So today we are going to talk about sleep disorder in children, which also known as childhood insomnia. So childhood insomnia can be divided into three types, which are the behavioral insomnia, psychophysiological insomnia, transient sleep disturbance. But the focus of today will be behavioral insomnia, which is most commonly seen in young children who age 0 to 9 and but may persist into middle childhood and beyond. Talking about the epidemiology, we can divide them into 4 age groups. So night waking is one of the most common sleep problems in infants and toddlers. So children over the age of 6 months tend to stay awake during the night for about 25 to 50%. So up to 10 to 50% of toddlers will have night waking problem. So up to 20% of preschool age children have insomnia symptoms with an increased risk in those with underlying comorbid medical condition. So more recent survey suggests that there are about 20 to 40% of school age children have insomnia symptoms and are more commonly seen in girls than boys. So recent study also suggests that about 11% of adolescents have significant history of insomnia, and there's also increased risk in in those who have neurodevelopmental problems, for example, autism or intellectual disability, and also those with psychiatric disorder are at particular high risk in sleep disturbances. So there are 3 associated conditions which can actually cause the behavioral insomnia. First is the insomnia related to sleep onset association. So in this condition, the child has actually learned to fall asleep under certain conditions or has a specific sleep association that typically require parental intervention. For example, being rocked on the bed, which the conditions are usually readily available during the bedtime. So during the night, when the child actually wake up for no reason, then they can't actually get back to sleep unless the same condition are provided. So as a result, they will actually cry in order to signal their caregiver so that they can have the same condition provided. And as a consequence, the child will have prolonged night waking and result in insufficient sleep. So the next condition is insomnia related to inadequate parental limit setting. So this condition is most commonly seen in children with preschool age and above. So this is characterized by active resistance, verbal protest, and repeated demand at bedtime rather than nighttime waking. And this disorder is most commonly developed from a caregiver's inability or unwillingness to set consistent bedtime rules and enforce a regular bedtime. So if this condition sufficiently prolonged, then the sleep onset may be delayed and result in inadequate sleep. So the last condition will be insomnia related to excessive time in the bed. So these are children whose parents' set time is in bed exceed their sleep needs, resulting in prolonged bedtime trouble, night waking, or early morning awakening, or in some condition there may be combination of all these 3. So next. So this is a schematic representation of a child whose sleep requirement is actually 10 hours but is exited in 12 hours sleep time in the bed. So these are the conditions that may happen to this child, which is having a struggle during the bedtime, night waking, and early morning awakening, or maybe there is combination of these three. So in order to solve this problem, in order to solve this problem, we need to reduce the sleep window to match the sleep needs for the child. In this case, 10 hours. So we can delay their bedtime or wake them up early. And in assessing sleep problem in children, we can actually use this best sleeping screening tools by asking about 5 sleep areas, which include the bedtime issues, excessive daytime sleepiness, night awakening, regularity and duration of sleep, and lastly is about the snoring. So next, if the primary problem is either bedtime resistant or difficulty initiating or maintaining sleep, then the most likely cause will be behavioral sleep disturbances. And talking about the management, I would introduce sleep hygiene. So sleep hygiene is a behavioral and environmental practice that is developed in 1917 as a method to help people with mild to moderate insomnia. A good sleep hygiene can actually increase your chance of getting a restful sleep and promote your productivity, mental, physical well-being, as well as your overall quality of life. So there are actually 14 habits that can be practiced in order to help you to get a good night's sleep. So firstly, we have to stick to the same bedtime and wake time every day, even on weekdays. So especially for children, if they're staying up late during the weekend and trying to catch up their sleep by sleeping in, this may actually mess up with their sleeping schedule for several days. And we need to know that bed are only for sleeping. Laying down on bed and doing other things, for example, watching TV, will actually make your brain harder to associate your bed with sleep. And so obviously we need to have a comfy and cozy room, which especially for children, they need to have a very cool, quiet and comfortable area, room. And alarm clock are only for waking up. So for children who tend to stare at the clock, waiting and hoping to get asleep, should actually turn the clock away from them. And next is have a bedtime routine. For example, brushing teeth, or wearing a pajamas, or reading a storybook before sleep can actually help your kids to associate this routine with sleep. Right. So we can.
So you should go into the room until 15 to 20 minutes before you fall asleep. It's because we don't want you to, don't get onto the bed lah. 20 minutes, and the room should be quiet and cool. And as you said, no gadgets, no toys, nothing. It should just be. Some people have like fridges and all sorts of things in their room. So computers also not in your.
So next is start the day off right with exercise, because exercise in the early morning can actually help the child to stay alert and help them to focus better, and this may even help them to get tired at the late evening. And obviously we need to avoid giving them caffeine, for example those soda, chocolate, tea and also coffee. So if your child can't sleep on the bed, or they are just turning on the bed, then just get them out from the bed by doing some less stimulating activities like reading a boring books like their textbook. So once they get sleepy again, then they can go back to their bed. So the ideal time for a child to sleep is actually when they are drowsy but still awake. And we also need to avoid them sleeping on places other than on their bed, because this will help them to associate their sleep with if they are sleeping in other place. So next is cuddle up with a stuffed animal or soft blanket. So by giving a child a security object is a good transition for them to feel safe when the parent is not around with them. So next is we can do some quiet, calming and also relaxing activities before sleeping. For example, listening to soft and calming music. And we need to avoid doing those excessively stimulating activities like playing video games before sleep. And we can also introduce children on how to relax by practicing some technique like take a deep and slow breath, or imagine something that's positive image like on the beach. And next is bedtime checkup should be short and sweet. So the purpose of bedtime checkup is actually to let the child know that you are there and they are alright. So the briefer, the shorter, the better. And lastly is maintain a sleep diary by tracking the nap time, bedtime, and also waking time, and also behavior. So to actually identify the patterns and work on a solution if there is anything not going well again. And yeah, that's all for the sleep.
Just a couple more things, because this occurs in childhood, parasomnias. So parasomnias are things like night terrors. Night terrors, the child wakes up in the middle of the night looking very scared and is crying and then goes back to sleep, but they don't actually remember what happened. They don't remember why they woke up. Nightmares, the difference between nightmares and night terrors is nightmares you actually remember what your nightmare is. And also, there's another type of parasomnia. Uncommon sleepwalking, there is a family history with sleepwalkers. Most important is to make sure that the whole situation is safe for the child who's sleepwalking. Yeah, so we find sleep hygiene helps with this as well. Things like nightmares and night terrors they go later on. They commonly occur from 3 years old to about 8 years old. Yeah, nightmares can continue for longer, but it is also reassure the parent lah. Sleepwalking, you need to make sure that the whole environment is safe.
So good morning everyone. So the last part of the seminar is school refusal. So we'll first look at a case. This patient is 12 years old. He comes with a history of anxiety. He begins to have more anxiety symptoms since last year when he entered middle school. He started developing some stomach aches which caused him to miss school, and he was referred to the gastroenterologist and there was no significant clinical findings. His anxiety increased and he had more difficulties going to school. He refused to go to school and he refused to get on the bus. And his father drove him to school, and when he was dropped off, he started crying and he continued to clung to the father, not wanting to leave his side. Actually, the patient developed panic attacks when the father left, and at school, he was seen that he's not eating during the classroom. The patient began to miss school, and initially he missed a few days of school a month, but then he began to miss a lot more, missing 1 to 2 per week. He continued to complain of stomach aches and headaches, and he had crying spells and panic attacks on school days. He was referred to the therapist and he began to have a regular appointment, but however, it did not resolve the anxiety, and he continued struggling with the anxiety, and he continued to miss school frequently. So the patient's parent met with the physician to discuss the possibility of her staying out of school for a month to decrease his stress, and they asked the physician for a letter of excuse from the school for medical reasons. So,
And Malaysia is not middle school.
sorry.
I said this is not a Malaysian.
No, this is not Malaysian. So let's highlight the key presentation and expressions of the child. He comes with history of anxiety. He started developing stomach aches. He is missing schools, and the anxiety keeps increasing. He actually shows physically that he doesn't want to go to school by clinging to the father. He has panic attacks. He's avoiding eating lunch, and the absence of absenteeism keeps increasing and is not improving. And also his anxiety is not improving. So
He's also having psychosomatic symptoms
Yes.
like stomach aches and
Yeah.
headaches.
So actually, the definition of school refusal is a significant reluctance to attend school and or difficulty remaining in school for an entire day. But how do we differentiate it from a child that just generally doesn't want to go to school because maybe he hates school or he just doesn't want to go? So there's a couple of elements to consider. So first, there's absenteeism. Of course, they will have excessive absence, and they will present with emotional distress. Usually, it's anxiety or fear or depression, and these emotional distress, as you can see from the case, it manifests to headaches, stomach aches, and the refusal is consistent, and they persistently doesn't want to go, and they either express it actively or passively. So in the case, there was active expression of refusal, like clung to the father, but there are some instances where the patient present with passive refusal, such as being withdrawal, being silenced. In school, refusal, the duration is usually lasting up to 4 weeks, and the behavior is persisting. It is not a temporary behavior to a short-term stressor. So we have to recognize that, and they will come with impairments of such as academic impair. So obviously, if the child is not going to school, he or his academic performance will decrease. They will also be present with social and emotional dysfunctioning. We have to also rule out that it is not truancy. So truancy is, like I said before, the child doesn't want to go to school because he wants to do more pleasurable activity outside of the school, or sometimes there are some rebellious activities they want to engage in instead of going to school. So actually, school refusal is fairly common. It occurs approximately 5% of all school-age children. It is both equal in boys and girls. It is seen, as the pattern is seen, that it peaks at the ages of between 5 to 7 years, then it decreases, then it peaks again between 11 and 14 years. And there has no socio-economic differences seen.
So if you look at those age groups, it's usually when you go to either primary school or when you go to secondary school. Yeah? So with transitions.
So here's a list of risk factors of school refusal. So it is seen that children that has anxiety disorders such as separation anxiety, social anxiety disorders, or generalized anxiety disorders are seen to have higher risk of developing school refusal. Children that present with a previous traumatic experience, they are seen to have more prone to school, not going to school, such as abuse, neglect, or accidents. Next is the family factors. So what happens at home will obviously really impact the child. So if the family is more or less dysfunctional, or there's inadequate parental support, so this can really impact the child to refuse to go to school. And next is academic difficulties. So some children who has like learning disabilities, or they have academic pressure, or they have fear of failure, or they may feel embarrassed, so they might want to go to school because they may be not unable to meet expectations, so they tend to avoid going to school. Again, peer relationship problems. As Yuan mentioned earlier, they may be facing bullying, so that may cause them to refuse to go to school. Lastly, another risk factor is mental health conditions. So certain mental health conditions such as depression and oppositional defiant disorders, and it's seen to be associated with school refusal. So like I said earlier, we need to differentiate school refusal first against truancy. So it's a nice table to differentiate the two. So school refusal usually presents with emotional distress, such as anxiety, temper tantrums, depressions, and also somatic complaints. In truancy, you wouldn't see the excessive anxiety or fear. Usually in school refusal, the parents are aware of the absence, whereas in truancy, the child often hides their absence from the parents and teachers. In school refusal, the absence is of significant antisocial behaviors, such as there's no any antisocial behaviors in school refusal, and such as one of the examples is juvenile delinquency. So you wouldn't see that here, but in truancy you would more or less see it, such as behaviors like lying, stealing. So, and like I mentioned before, the rebellious activities. Lastly, in school refusal, during school hours, the child usually stays home because for them it's considered to be a safe and secure environment. But in truancy, the child might be going somewhere else instead of school to pursue more attractive activities outside the home. So I've more or less listed the signs and discussed the signs and symptoms, such as the fear, the behavior becomes more prominent and difficult to get to school. They may present panic symptoms, crying episode, temper tantrums, but a more serious sign to take attention to is threats of self-harm. So the assessment and diagnosis of school refusal initially, in general practice, we should include and consider all the precipitating and pre-perpetuating factors in the child, family, and school. And this includes an understanding of the child's emotions, such as fear of loss of a parent, needing to protect a parent, excessive fear of situations within the school, such as bullying, and also we need to take in mind if there has been any changes of the teacher, or the teacher and the class environment is not appropriate for the child, and or the child has a problem with it. Of course, we do a thorough examination to assure the child and the parents about the physical symptoms. And also we can get information from the school about the child behavior. We can request for a detailed academic progress and record attendance to see if there's any specific patterns. Managing school refusal, first we can suggest cognitive behavioral therapy. Next is we can suggest dialectical behavioral therapy, which is seen to be effective in treating anxiety. Actually, DBT has four things included, and it is in two sets. So 2 sets of acceptance and oriented skills, and 2 sets of change oriented skills. We can utilize selective serotonin uptake inhibitors, which can help with depression and anxiety, and also utilize benzodiazepines. We have to keep in mind that there's risk of addictions.
We don't use benzodiazepines in children.
Okay, so we can scratch that. Okay, thank you, and here are all our references.